Welcome back to OpenNet School. In the last session, we have discussed about hepatic encephalopathy, the triggers for precipitating factors, and the underlying cause and clinical features. Today, I'll be discussing general management of hepatic encephalopathy, followed by specific management. Let us start. So, what is hepatic encephalopathy? Hepatic encephalopathy is a reversible neuropsychiatric dysfunction due to impaired liver function. And the most important cause is increased ammonia. Plus, there are systemic inflammation, other false neurotransmitters, etc. And we basically divide into overt hepatic encephalopathy and covert hepatic encephalopathy depending upon the clinical manifestations. And any patient you have to triage by looking into the grades. The grades are grade 1 is minimal, only outpatient management if a caregiver is available. Grade 2, characteristically there is a flapping tremor and admit the patient if worsening, lethargy and confusion is increasing. Grade 3 and grade 4 are definitely, they should be hospitalized. They may need ICU care and may need intubation depending upon the stage. Always search for triggering factors. Think about the general supportive care. Prevent dehydration. Correct electrolytes, especially the potassium, and sometimes sodium. Hyponatremia and hypokalemia and alkalosis. These are three metabolic conditions that can worsen. Have a safe environment, prevent falls, avoid sedating drugs, especially benzodiazepines. Because last time we have discussed that the endogenous benzodiazepines is one of the neurotransmitters that is involved in hepatic encephalopathy. In the general care, remember prevention of dehydration and correction of electrolytes. Mentioned about the potassium importance. So nutritional care, there is no protein restriction. There's a tendency to restrict the protein. Calories should be 35 to 40 kilocalories. Protein 1.2 to 1.5 grams per kilogram for ideal body weight. Oral nutrition, mild and moderate cases, small frequent meals and bedtime snack. This will prevent catabolism and decrease the amount of ammonia level. Restart normal diet when the patient is improving. So we have discussed about the general management. Now we go to the specific treatment. First principle is identify the precipitating cause, about which we already said. The GI bleed, infection, especially spontaneous bacterial peritonitis, UTI, and pneumonia. These are the important things you should exclude. Hypokalemia and metabolic alkalosis, renal failure, hypovolemia, hypoxia, sedatives, especially benzodiazepines. Hypoglycemia never miss. Constipation, very rarely HCC, hepatic vein thrombosis, portal vein thrombosis. So treat the triggering factors that will improve the and will better and quick recovery. Now, as mentioned, correction of hypokalemia. Low potassium will increase the renal ammonia production. Correct it, but don't restrict protein. This is an important point to be kept in mind. Now going to the pharmacotherapy, the first line treatment. What is the first line treatment? It is non-absorbable disaccharide like lactulose or lactitol. In the last session, we have discussed about the disaccharide lactulose. Lactose is a disaccharide that is not acted upon by intestinal enzyme. So what will happen? It will reach the colon. In the colon, it is acted upon by the bacteria, and the bacterial enzymes will convert it into lactic acid. The lactic acid releases hydrogen ions. The ammonia will combine with the hydrogen ions to form ammonium, NH4, and which will not be absorbed. That is one mechanism. Second is it will prevent the constipation and will help in the avoiding the constipation, and loose stools are produced. So this will lead on to again decrease the production of ammonia by the intestinal bacteria. So what is the dose of lactulose? Lactulose is given 30 to 45 ml 2 to 4 times a day. Goal is 2 to 3 soft stools per day. That should be the dose. Avoid diarrhea because this may worsen hepatic encephalopathy. If it is not orally possible, we can give lactulose enema. Avoid it nasogastric tube because of the risk of aspiration. So the first line treatment is lactulose. We explained the mechanism. So as mentioned, it is an intestinal bacteria which predominantly produces ammonia, even though some amount of ammonia is produced by the enterocytes. So in order to sterilize the bowel, you give antibiotic. One of the the antibiotic choice is rifaximin, 550 milligram twice daily per oral. And especially the patient is not improving in 48 hours, or in case of recurrent hepatic encephalopathy, you should definitely start on lactulose. This is not a substitute for, but add lactulose. So rifaximin is not a substitute. You can give it for up to 24 months. It is safe. So first line is lactulose. Second line is adding rifaximin. Hope this point is clear. Other drugs which were tried earlier, one is neomycin because it's not absorbable. But nowadays it has been found that it can also produce ototoxicity and nephrotoxicity, and nowadays nobody is using it. Other antibiotics rarely given are the vancomycin, metronidazole, but it is not routinely used. Polyethylene glycol, again, not routinely given. So first line drug is lactulose, second line is rifaximin. Again, rifaximin is adding rifaximin. So what are the key points you should remember? Always the triggers and drugs. Lactulose is main, rifaximin is add-on, don't restrict protein, correct the hypokalemia, look at the precipitating factors. So hope this session was useful to you. Stay tuned. Thank you.